The standard objective in psychiatric rehabilitation is straightforward: reduce the severity of symptoms and achieve clinical stabilization. Yet, practitioners frequently encounter a paradox. A patient's psychiatric metrics, like their PANSS scores, can show marked improvement, while their capacity for basic independent living remains low. Symptoms decrease, but independence remains flat. This shaded area represents the generalization gap. It is the failure to transfer clinical gains into the complex environment of the home. When this gap remains unaddressed, patients who appear stable in the clinic often struggle with medication adherence, basic personal hygiene, and maintaining community placements. The barriers preventing this transfer are neurological. Deficits in cognition, slowed processing speeds, and executive dysfunction block the application of new skills outside the clinic. To bridge this gap, treatment must focus on adaptive functioning. Adaptive functioning is the tangible measure of how well an individual manages everyday life. It encompasses the conceptual, social, and practical domains required to navigate the world safely. Relying solely on clinical test performance or symptom management overlooks the actual requirements of daily survival. Success in rehabilitation is dictated by adaptive functioning, which serves as the primary determinant of whether treatment gains translate into durable recovery. Without a model that actively targets these functional skills, symptom-focused care often leaves patients unprepared for the executive demands of independent living. How do clinicians engineer a treatment plan that actually survives the transition from the controlled clinic into unpredictable reality? The answer lies in the four-pillar scaffolding model, a structured blueprint designed to build and support adaptive functioning. The foundation is Pillar 1, cognitive retraining. This establishes the baseline capacity of the individual's mental architecture. The intervention targets underlying neurological functions directly, working to restore attention, working memory, processing speed, and executive reasoning. However, abstract cognitive drills will fail if they operate in a vacuum. To be effective, these exercises must be explicitly tied to everyday functional goals. Upgrading the brain's internal hardware is insufficient if the patient lacks the operating software to run it in the real world. That operating software is Pillar 2, metacognitive strategies. Metacognition involves teaching the patient to consciously step back and monitor how they think and how they act in real time. In practice, this means actively training the individual in error detection, self-correction, and structured goal setting. The most vital habit to instill within this pillar is the stop, plan, do, review routine, forcing a deliberate pause before executive action. Metacognition serves as the true engine for skill generalization. It builds the critical insight necessary for individuals with trauma histories or chronic serious mental illness to navigate daily stressors. While cognitive retraining and metacognition successfully rebuild internal capacity, they are rarely enough on their own. Most patients with serious mental illness will eventually hit a permanent cognitive ceiling. When internal cognitive recovery reaches its physiological limit, the intervention strategy must pivot outward. This outward pivot is Pillar 3, compensatory aids. We move from internal restoration to external scaffolding. The core function of these aids is cognitive offloading, transferring the executive burden from the patient's brain into their physical environment. Concrete interventions like phone alarms, strict visual checklists, daily pill organizers, and explicitly labeled storage. Practitioners should view these tools as permanent components of the patient's environment. By utilizing them as long-term prosthetic environments, clinicians ensure the patient can maintain independence even when cognitive recovery is partial. Neurologically, these aids bypass damaged neural pathways entirely, drastically reducing the demand placed on the patient's compromised working memory. Because they require minimal internal capacity to deploy, external aids are often the most immediately useful interventions during the early stages of rehabilitation. Systematic external offloading supports patient safety by reducing the executive demands of everyday life until they match the patient's existing cognitive capacity. Up to this point, the first three pillars remain theoretical. They hold no clinical value until they are rigorously tested against reality. That test occurs in Pillar 4, applied real-world practice, the final layer of our model. The internal hardware, software, and external prosthetics must be deployed into specific, observable domains of daily living, beginning with self-care and home living. Success in home living requires breaking complex actions down through precise task analysis, step-by-step repetition, and direct environmental modification by caregivers. The second critical domain is health management, an area that demands intense working memory and consistent behavioral follow-through. Here, the model applies strict external cues for medication adherence, daily symptom tracking logs, and systems for managing appointment logistics. The third domain is financial management, a uniquely vulnerable area that requires explicit and proactive clinical attention. Handling finances is highly demanding on executive function. As a result, it is routinely the very first complex instrumental skill to decline under cognitive impairment. Practitioners must implement mandatory financial safeguards, including automatic bill pay, dual oversight banking, and formal capacity evaluations when a patient's judgment is compromised. The effectiveness of the clinical scaffold depends on its rigorous application across these specific domains before the patient is discharged. When constructed correctly, these 4 pillars, cognitive retraining, metacognition, compensatory aids, and real-world practice, function as a single unified system. The ultimate goal of this rehabilitation model is the moment when the visible clinical scaffolding dissolves into the invisible daily routines of a discharged patient. For administrators and staff in residential treatment settings, this framework provides immediate operational value. It replaces abstract symptom tracking with highly observable, measurable behavioral goals. It systematically clarifies discharge planning by sorting a patient's capabilities into 3 concrete triage categories. It identifies exactly which skills can be neurologically improved, which specific deficits require permanent environmental compensation, and which vulnerabilities necessitate long-term institutional support. This leaves clinical professionals with a precise standard for measuring success. If a patient cannot independently manage their hygiene, take their medications, or protect their finances, the recorded improvement in their psychiatric symptoms has failed to translate into a functional recovery. To achieve durable, real-world recovery in populations with serious mental illness, adaptive functioning must be the core target of the care plan.